What does public health actually look like inside the clinic? In this panel discussion, three professionals from completely different industries share how they explain public health in plain language to the people closest to them. Listen in to hear how proactive thinking, relationships, and systems level solutions show up in fields you might not expect. You're listening to the PHEC podcast, episode 467. Welcome to the Public Health Epidemiology Conversations podcast, where we have honest conversations with public health professionals who are creating meaningful impact in communities around the world. They know that the field of public health touches everything. I'm your host, Dr. Charlotte Hughes Huntley, and today we're exploring the fascinating journey of our guests and diving into another conversation that bridges different perspectives with the practical wisdom you need to fuel your impact. Greetings, everyone, and thank you for joining me on this episode. My name is Dr. Charlotte Huntley, epidemiologist, entrepreneur, author, and your host every Tuesday since 2017. I've spent over 2 decades working at the intersection of health, community, and meaningful change. My book, The Public Health Consultant, Expertise, Entrepreneurship, Greater Impact, publishes December 2026 with Johns Hopkins University Press. Outside this podcast, I lead Dr. C.H. Huntley LLC, partnering with large nonprofits, government agencies, and tribal nations on strategic planning and implementation. Lately, much of our work is centered around workforce development, helping our organizations build the capacity they need to serve the communities that they are serving very well. That work and this podcast are driven by the same passion, helping public health professionals and the organizations they lead create real change in communities they serve. Let's dive in. I am very excited to introduce you to my guests for this episode. They bring 3 very different professional lenses to share how they explain the meaning of public health to the people closest to them. We have a physician researcher, a transportation safety lead, and a clinical pharmacist. We talk through the moments that shape their understanding of the field, from humanizing population-level data to tracing healthcare barriers back to their root causes. They explore why relationships across disciplines matter, how storytelling makes abstract concepts real, and why public health belongs in every industry. This conversation offers practical language for talking about public health with anyone in your life. Let's connect that conversation right now. Welcome all of you to this new episode of What is Public Health? It's actually a part of a series that we have on the podcast. I'm excited to have you join me. We've been chatting a little bit before I hit record, so I'm really excited to get to know each of you and to hear what you have to share on this conversation, this ongoing conversation. So we're going to start with a round of introductions. I'm going to ask you to introduce yourselves. Tell us a little bit about what you do, where you are, just whatever you'd like to share. And we'll start with you, Salome. Please introduce yourself.
Hi, everyone. My name is Salome Adafen, and I'm a physician researcher. So I basically went to medical school back in Nigeria, my home country. And after that, I decided to come to the US to do a master's at Johns Hopkins School of Public Health. And so I did do one in public mental health, and I also did one in bioethics. And my journey has pretty been shaped by the idea that I just wanted to help people. Growing up, I just always had that compassion. And for me, as a Nigerian student that was supposedly very bright in school, most of my teachers said, if I wanted to help people, the best way to do that was to be a doctor. So I then decided to go to medical school. And in medical school, we did do courses on public health and some on mental health. And for me, that kind of really shaped how I started thinking about healthcare and how to care for people. And I started realizing that sometimes you don't only have to be in the clinic, in the 4 walls of the clinic to help people. And sometimes your impact might be felt in a bigger way when you leave the 4 walls of the clinic. And so that kind of pushed me to apply at Johns Hopkins. And then I was really passionate about mental health because for me also as a Nigerian, as an African, I realized that mental health was a conversation that was not readily had. And even on the aspect of ethics, that also kind of tied into my background in Nigeria or mental health. I realized that there was not really like a lot of ethical guidelines in taking care of mentally ill patients. It was until like 2023 that the Nigerian government revised the act, the Mental Health Act, actually from the Lunacy Act that was given to us during the colonial time. So it really just pushed my passion to, I wanted to change the narrative of mental health in Nigeria, in Africa, and I still do. So that's just really what has spurred my journey. But at the same time, I still miss my patients and being able to interact directly with them. So I'm kind of at a crossroad right now. I'm still doing research, but I still hope to like go back to the clinic and be able to still impact life. Because at the end of the day, the reason why I really came into this was I just wanted to help people around me. That was it.
Oh, wow. Thank you for that introduction. That's wonderful. You just explained public health to its core. That's wonderful. Angie, over to you. Please introduce yourself.
Hi, everyone. My name is Angie Byrne. I am the safety practice lead at Tool Design. I've been at the company for just over a year now. Prior to that, I worked for 18 years at the U.S. Department of Transportation. During my time at USDOT, worked in a variety of surface transportation. I worked with behavioral traffic safety. I worked with rail and transit, large trucks and buses. I worked a lot with law enforcement over the years, emergency responders. So doing just a little bit of everything while I was at the USDOT. But, one of the things that's been consistent throughout my whole career is I've described myself as a public health person who's infiltrated the transportation space because I'm not a planner. I'm not an engineer. I'm not law enforcement. I'm not an emergency responder. So I am very much someone who is infiltrating the space and trying to introduce public health concepts into a world that really needs them. So that is a little bit about myself.
Thank you for that introduction. You just reminded me, I had dinner with some friends a few days ago, and one couple, the husband's already retired from DOT, and she still works there at the state level here. So we had some deep conversations about GIS
Oh,
and
cool.
how it's used in DOT versus in EPI or in public health mapping. So we went
Mhm.
down a long tangent on that, but
That's amazing.
yeah. And last but not least, Brian, please introduce yourself.
Of course, and thanks so much, Charlotte, for having us on here. This is a really cool mixture of guests, and I'm really excited to kind of get this conversation started. And so my name is Brian, and I'm a clinical pharmacist working with Brown University Health in Providence, Rhode Island. I specialize in what we call medication reconciliation and transitions of care. So I primarily lead a service that helps identify medication discrepancies, whether they're safety related or related to things like accessibility and affordability at the time of hospital discharge. So I like to say, similar to maybe what you said, Angie, is I definitely don't have necessarily a public health formal training background, although I'm considering doing that soon. But in the last few years, particularly in this role, seeing day in and day out the challenges that patients face with obtaining their medications, anywhere from transportation to their pharmacy or their refill appointment, all the way up until their insurance plan being suboptimal or sometimes not even existent, and everything in between. And so I really found passion in trying to help patients understand the ways they can save money on their prescriptions, how to navigate the wildly complex medication and prescription insurance system in the US, and also collaborate with a lot of other disciplines that work on population health and public health, like social work and case management and physicians. It's such a great space to be in, and I've really enjoyed it so far, and then definitely learning to find that intersection between my profession of pharmacy and public health. So really excited to keep exploring that path.
Yeah, that's amazing. I talked to a whole lot of pharmacists who bring the boots on the ground, a very different perspective and connection to the community where they're seeing patient experiences at a very different angle than, say, primary care. And I wonder, in your case, did you expect this in the role when coming in, or is it just something that you were surprised?
Yeah, that's a good question. kind of knew coming into taking this role that I was always really passionate about that sort of problem solving and helping fill in that big gap in the care transition from one place to another, right? So from the hospital to the clinic or the outpatient space or the nursing home. And I like complex problem solving and that. But I think just the sheer volume of discharges that I've reviewed, myself and my team, we have found a lot of other offshoot challenge areas that relate to, quite frankly, the way the healthcare system is set up. And it comes right in front of your face when everyone's sort of scrambling to find an alternative to this expensive medicine that the patient really needs to treat their blood clot or improve their heart disease. And I've really enjoyed sitting in that complex space, but I definitely don't think I knew how consistent and how maybe persistent the problem would be and how much I would feel compelled to address it from like a systems lens.
Well, thank you for that. Thank you all for those introductions. And yeah, I think all of your brains are probably starting to tick and turn here because you each are absolutely doing the work of public health. And I think this awareness of public health, this understanding of public health from each of your perspectives and the work that you do, you have an opportunity to really advocate for public health and from whatever we all do, but especially in a very impactful way for each of you. So the question that I have for you, and this is really just to help each of us gain and refine our conversations, our plain language conversations to folks to spread the understanding of public health so that we're not so easily removed and defunded. We can add more value to public health. You know, people often say when public health is working really well, it's silent. And to a great degree, that's true. But we need to still sell this industry and sell this work and get funding and secure funding so that we can continue to do the work. So my question for each of you is really, how are you explaining public health to your people closest to you, friends, family, maybe even coworkers that are maybe not doing the same work, colleagues, but how are you explaining to them in plain language in a way that they can understand? And I'm going to start in kind of the same order. Salam, I'm going to start with you. I'll just ask you to, share with us, how do you explain public health in plain language and what do you say and how does that work for you?
Well, for me, I really try to explain public health as public health is simply just people. That's how I see it. And that's how I really come to see it. Like the research, the policies, at the end of the day, people make these policies. People are affected by these policies. Changes are made by people. People are affected by diseases. I feel like if we can understand that public health is me and you coming together to protect ourselves, coming together to be like, this is an issue in this community, and then we need to resolve it. Another way I would see public health as is that public health is very selfless to an extent, in the sense that even if it's affecting 1% of the population, you should not be comfortable with 1% being affected. Even if it's affecting 50% of the population, that's not the only reason why you should be like eager to do something about it. One person's problem is my problem. So it's kind of also being your brother's keeper, just being there. I know like it's more of used in like a religious setting, but I see it as being your brother's keeper. Like your burden is my burden. Your worries are my worries. If it's not working, I know the world cannot be perfect. I know that the world cannot be like put on the same scale for everyone because that would be like a bit unrealistic. But if we can make it better, if we can to an extent make it more even, then you're changing someone's life. So I would call it like being your brother's keeper, just being there for the other individual.
Thank you for that. I like that. It's selfless. And I like that you put that in context. I love the word community. And it aligns with me personally and through business. So it's really what you're saying makes me think of that. You just can't, it's not just me, it's my neighbor. It's, it's really pure compassion. And I also like your mention of humanizing those numbers. So that 1% or that 50%, that represents some people that are really suffering and it shouldn't be okay. I definitely understand what you're saying. I like that. Thank you. Angie, what about you? How do you explain public health to friends, family, colleagues in a way that, they can easily understand?
There's two major things I think that define public health. One is that it's proactive. So often in our society, everything is reactive, whereas public health tries to buck that trend and be proactive, not wait till a problem happens or not wait till a problem gets worse before we go to solve it. So that's the first thing. The second is that public health is about population level change. And as opposed to, like Salome talking about a doctor treating a patient, public health treats populations. And that's a huge shift in how we try to address things. So often in my field of transportation safety, it's very individual. Like, oh, we need to address this person caught speeding. We need to address this person driving impaired, instead of just addressing the population of everyone operating in our network. And I think there's three critical ways to achieve that proactive and population level change. One is to think in systems. Like in transportation safety, we often talk about a safe system approach. So we're talking about safer vehicles, safer individuals, safer roadway environments, safer speeds, emergency response, and post-crash care for those who have been impacted by traffic violence. The next thing is, and I love that Salome and Brian have both mentioned this, is relationships. Like, you cannot work across so many different disciplines without having critical relationships and maintaining those relationships. And I think the final way this is accomplished is through creating redundancies. Like, so often we look for that like silver bullet, like, oh, we just do this one thing, it will solve all our problems. Life isn't that simple. And so you really need to create those redundancies and build those resiliencies throughout a network to truly achieve public health. I'll kind of give an example of this in action with the field I work in transportation safety. So approximately 39,000 people passed away last year in traffic crashes. 7,000 of those roughly were pedestrians. This is a major issue in the US. Not just that we have so many people dying on our roadways, but a large percentage of them is people outside of the vehicles. But what we don't talk a lot about in those numbers, and this isn't really well captured it's not captured in the national data sets, but for communities who have looked at this, of those pedestrians that are dying every year, depending on the cities that study it, they found between 40 and 60% of those people are unhoused. How are you going to talk about transportation safety if you're not talking about those who are unhoused being a large percentage of your fatalities? So that's how I explain to people about what is public health and transportation safety, because it goes beyond our traditional silos of thinking. Because like in my field, people are like, yes, a lot of people are dying in traffic crashes. Pedestrians are the big issue. And then it's like, did you know that a lot of those pedestrians are unhoused? Where it's studied, and people are like, no, I didn't know that. So I love to give that as an example.
Oh, wow. That's a great example. I mean, it's a sad reality. I'm not celebrating that fact, but it's a great example of public health through this transportation lens, but also pointing to the overlap. Like you said, it's relationships. It's not just that the Department of Transportation can solve all of its issues. It's really overlapping with other, conditions and issues. Yeah, it's a great example, a great story. Thank you for that.
No problem.
What about you, Brian? How are you explaining public health to your friends, colleagues, coworkers, neighbors, family members, just people around you in a way that they can easily understand?
Yeah, and I think this question is so critical because I think a lot of maybe the general public has either maybe no image of what public health actually is, or they have a very vague and one-dimensional view, not of anyone's fault, but it's, I think, sometimes by way of podcasts like this, where we show that people all across the workforce are doing public health adjacent work is so critical to explain it. So I think what pretty much everyone has said so far is I think public health is so grounded in fixing the system in a proactive upstream way, and really also identifying that the system which is a very broad term, but the system, particularly the healthcare system is what I'm referencing, is you can always probably trace an issue with, like in my field, a medication error, or someone can't afford their critical medicine and they come back to the hospital wasting money and resources and time, for something that was very much preventable. You can probably trace that back for 4, 5, 6 steps to a systemic challenge, whether it's systemic bias, whether it's policy that is outdated, whether it's active choices from the government, just to be blunt. I mean, there are times where almost every situation I come across when I'm looking at a discharge, I, in my head, can start to walk backwards, right? And say, well, yeah, they can afford this critical life-saving medicine like insulin, for example, but let's shift it from the patient level, which is extremely important. And I'm very happy that I still can work on direct patient care and such, but there's so much value in stepping back and stepping further up the stream and saying, why did this condition even get created in the first place? And can we fix it? And how can we fix it? And the other thing I think about with this question is, some of you may have seen that graphic of like what percentage of someone's overall health is influenced by actual clinical care. And it's such a wonderful graphic, but I think that really illustrates this too, is that traditional, what we think of clinical care or patient care probably accounts for maybe 15 to 20% of someone's overall health, just like what we think of as healthcare. But what else is in that graph is behavioral health and mental health and environmental health and access to food, water, and shelter. So I think what you said, Angie, really resonated, is that we see this sometimes in my field. If we're starting all these new fancy guideline recommended medications for a patient, but then we say, oh, well, they are unhoused and they're currently staying under a bridge and they don't have a way to store their refrigerated product, or there's risk of them losing their medicines or them getting stolen. Well, we're all the way back to square one. And a lot of those challenges are very much systemic. And I think of public health almost as like a big, massive quality improvement project that we all need to just tackle together in bits and chunks. And then maybe isn't glamorous or shiny or fancy work, but it's critical and it really affects everything downstream, especially in a lot of our fields, I think.
Yeah, really well said. I like that you reiterated the proactive, because when Angie made that comment, that resonated with me also. And you're absolutely right. If we kind of work some of these case studies back a few steps, we start getting to some of the root causes, real issues, where we can, these systemic issues, where it's all connected. I think that a lot of our colleagues are doing this work. I think a lot of the stories, like what your examples that you all are describing, some of this needs to be incorporated into some of those conversations. More of this needs to be incorporated into those conversations. I also like that, I'm going to say this and I'll give you all a chance to comment too, but I like how Angie emphasized relationships. That's really key. I think as we kind of work these back and start to identify some of these, systemic root causes, those relationships across industries, that is important, because we have to be reminded, again, to Salome's point, like the individual, the human component here, not just the numbers. So those relationships, remembering who we're working for and what we're doing in this proactive work, all of that's important in these stories. Just continuing. I think it was last summer, I sat with a group of legislators, and that's exactly what they were saying was needed in sort of a bipartisan effort, is connecting to the human stories, the human element of the constituents. Like when they think about whatever they're advocating for, it's the stories of the people that they represent. So I think as we do this public health work and we advocate across industries and kind of attack some of these systemic issues, it's really about bringing these stories that represent the humans and the people that are involved, not just the numbers, and that's coming from an epidemiologist who's always talking about numbers. But, it's the people and the story and the relationships. So I'm going to give each of you a chance to comment as we begin to kind of wrap up this. And we could probably talk about this for a while, but I appreciate the conversation and all that you've shared so much in your responses. But we'll go back around and give each of you a couple minutes to add any final thoughts or any comments that you'd like to put on. We'll start with you, Salome.
I would say that, okay, I would say two things that I think need to change or need to be different. Is one, I think public health is such a huge field. And if you decide to go like into it in whatever capacity, and I really like the fact that everyone here is like from different fields, and we could see how public health still plays a role in each of those fields. And for me, I feel wherever you like find yourself, just make it an opportunity to advocate for like better health for people. Because at the end of the day, again, that's you being your brother's keeper. And I really like the aspect where you spoke about stories, because the thing is that many of these things seem very abstract to you until you are brought face to face with it. And I personally, that was really my encounter, in the sense that I'd heard so much, like when you're first of all sitting in the lecture hall, because first of all, you take lectures before you actually go into the clinic or into the wards. And so you read about all these diseases, you read about all these like systems working together to keep your body together. And then it seems so abstract a bit, but then you go into the hospital, you go into the wards, and then you see someone actually having this disease. And just like how Brian mentioned, the fact that now this individual is not just the disease, there's the place of housing, there's the place of how they can afford medicine. And then, especially in context of where I worked in a low resource setting. So we had to not only think of, okay, we're treating this person, we have to start thinking of what are the family conditions to help this person? What are the things that could have been put in place earlier for this person to have been better? So even in a family setting, when choosing where you're going to live, what are the things that you're going to pick out for your family to ensure better health? Are we giving people that opportunity to pick that out? So I think that public health should be everyone's work in each field, like wherever you find yourself, just find a way to advocate for better health. Then lastly, I think that it should be introduced earlier. And I got this idea recently when I started working on something with a couple of my friends too as well. We're trying to write like a storybook to teach kids about different forms of addiction, especially in Nigeria, because we realized that that context was not really available for the children in that area. And also that context was kind of more filled with like fear mongering. And so people don't even have the proper education about these things. People don't even have the proper tools to protect themselves. But if you start introducing these tools quite early, like, of course, you have to write it in a way that will be more friendly and they'll be able to absorb it. But that's why you work with professionals and you don't work in a silo. But we need to start introducing these discussions earlier, not in adulthood. So people can start having these conversations and they realize that right from when they were younger, they were already being like part of protecting the health of other people. When children know the importance of vaccinations, when children know the importance of, okay, what are the effects of this? What are the effects of that? If we start introducing it a little bit into the system, people start having these conversations even before they come to adulthood. And then when they come to adulthood, they can make the right decision in terms of votes, in terms of policies. You already have an idea. You don't have to be at Johns Hopkins to be able to fully understand the policy and how it will affect you and your family. Instead, you already have some sort of knowledge, and all you might have to do is just maybe read up a bit. So I think I've said a lot. I hope that's enough.
That was really well said. Thank you. Thank you for adding great points. What about you, Angie?
Hearing this whole talk, I think we just need to acknowledge, like, this is hard. I mean, like, shifting people's mindsets of how to approach challenges. And as Brian, I loved you using the phrase taking things upstream. This is it's a mental shift with a lot of people, and it involves us working outside of our comfort zones a lot. Like, I can't tell you how often I'll speak to like engineers or something, and they'll be like, I need to learn engineering language to actually talk to them. I can't come at them with like the social determinants of health. Like, I'm just going to go way past them. So like, I need to learn their language first to be able to talk to them. And then once I kind of get to that level, they're like, oh, I get it. Okay. This is still hard, but like, I at least get now where you're coming from. And I love, Dr. Huntley, that you brought up, and like all of us to a certain extent have brought up how important storytelling is to make this a little easier. Another argument I use is like, even though this is hard, Like, people assume public health is expensive because it's hard. And I usually try to flip that narrative very quickly and talk, like, I think it's important to talk about the economics because you're all right. Like, we've talked about, these aren't just numbers, these are people. And, like, in my field, one of the examples I use in the economics case is like, just how much we're paying in healthcare for a person who's been impacted in a traffic crash, how much we're paying in liability claims to those families. Say it's a city vehicle that hits one of those pedestrians. Like, that's a lot of liability claims. I think a couple cities have looked at this, and some of those liabilities are over $1 million per person in some of these crashes. So, like, those are very important conversations to have too about the cost of it not doing anything, as opposed to the cost of waiting till it happens. And so, like, the economics, I think, is an important part of this conversation too.
Yeah, great points. I'm glad you brought that up too. Really just great points in addition here. And Brian, what about you? What are your final thoughts? What do you want to add?
Yeah, I think both of you guys have said it so well. And I really like, Angie, what you said about the cost of not working on this is so high. It's astronomical. And it kind of already is in many ways. But yes, we do have a guest, everyone on the podcast. Milo is very passionate about public health and he snuck through the door. So
That's okay.
But yeah, I think that the whole concept of understanding why these things exist and identifying that it is upstream, it is systemic, it is policy, it is maybe ineffective or limited regulation of large corporations or insurance companies that may make things more challenging for people. And so I think that the mixture of all of those things is something that is really hard, but the cost of not working together across professions with plenty of voices, both in the traditional public health world, if you will, and the folks who maybe will never get an MPH or never may sit in a room with public health officials, but are still doing adjacent work that they may not even know that what they're doing is public health. And so I think that's one takeaway I have just from talking to you all is I think we've got to get the concept of public health just out into the culture and into the people. And I think Australia does this really well, where they instill a lot of outside of even public health, like civics and advocacy and who is your elected official. It all relates. And I think if we work to show people that the barriers to learn about public health and engage in it are lower than you might think. And a lot of it is just understanding how the system works, or maybe not understanding how it works and wanting to figure out how. And combined with the patient level care or the pedestrian level interventions, the cyclist level interventions, in your world, Angie, but like also the larger context of a city or a village or a large metro area. I think the audience kind of shifts too in terms of what you can and can't do as far as interventions and maybe what's historically been done in the past. So I think, the biggest takeaway is this is an upstream, uphill battle, but it's important that a lot of us, and this is my shout out to any pharmacists listening, you can do it. You can at least learn a little bit, join your state affiliate public health organization. I'm a member of the Rhode Island Public Health Association for free through my employer, and the American Public Health Association has a lot of great content. And so I think advocacy and professional involvement are really some of the first steps there.
Fantastic. This has been an incredible conversation. There's so much to digest and think about. You guys have been amazing. I appreciate you for showing up and for sharing so generously, and your thoughts have been just amazing. So we'll definitely keep in touch. And in a moment, I'll let everyone know how to connect with you. But for now, thank you so much for being part of this conversation.
Thanks for having us.
Yeah, thank you.
Thank you. Thanks for having us.
I really hope you enjoyed that conversation as much as we did. What stood out most in this conversation is how differently each guest arrived at public health, yet how aligned they were on what it actually requires: proactive thinking, strong relationships, and the willingness to trace problems back to their systemic root causes. Whether you work in medicine, transportation, or pharmacy, the lesson is the same. Public health happens wherever people are paying attention to the systems shaping someone else's life. I hope this conversation gives you new language for explaining your own work and a reminder that your perspectives add real value to this field. I encourage you to connect with each of our guests from this episode and learn more about the work that they're doing. You can find the links to connect with them on the show notes page. The show notes page for this episode, which is episode 467, can be found at phecpodcast.com. Once you're there, just navigate to episode 467 to find the show notes. There's one more thing before we go. Remember that our podcast has an app and a private community that is independent of social media platforms. This is where you can engage with public health professionals around the world. In addition to being a part of this amazing community, your membership supports the production of this podcast and episodes just like this one. You can download our PHEC podcast community app in our mobile app store, and it is available for both Apple and Android users. You can also visit phecpodcastcommunity.com to join the community on desktop. All right, everyone. Until next time, have a fantastic rest of your day. Thank you for listening. The show notes page is where you'll find links to everything we discussed in this episode. To find the show notes for all of our podcast episodes, just visit phecpodcast.com.